septic shock. So you may get patients who have cardiac dysfunction also with peripheral hypoperfusion. So they may require adequate blood volume status and arterial blood pressure. So they recommended that adding dobutamine to norepinephrine or using epinephrine alone. So because dobutamine will help in cardiac dysfunction also and in improving the hypoperfusion also. In patients who had persistent hypoperfusion despite volume status, adequate volume status and blood pressures, levosimendan was not recommended. So monitoring. So how do you monitor? Non-invasive BP monitoring is not recommended. So they suggested invasive BP monitoring over non-invasive monitoring. In patients who were in septic shock, generally vasopressors should be started in a central line. But if it is not available, you should not delay it in maintaining the map. You should start it with a peripheral line also. So they recommended that when vasopressors are used peripherally, they should be administered only for a short period of time and in a vein which is proximal or in the antecubital fossa. So fluid balance. How do you judge whether the patient should have a liberal fluid therapy or a restrictive fluid therapy? So there was a trial, Andromeda shock trial, which demonstrated that by 2 hours, by the end of 2 hours, only 25% of the patients were fluid responsive. That means 75% were not fluid responsive. You had already given them enough fluid. So this classic pilot study was also done, which showed that a restrictive fluid strategy was feasible and showed significantly less fluid was used in first 5 days of the ICU. So mortality was reduced in this restrictive group, although it was not significant. Now, ventilatory strategies. They recommended that in patients who have sepsis-induced hypoxemic failure, respiratory failure, high-flow oxygen nasal cannula is better as compared to non-invasive ventilation, that is BiPAP. So protective ventilation should be used in patients with ARDS. Protective ventilation means that low tidal volume and high PEEP. They recommended that the plateau pressures should be achieved, should not go more than 30 centimeter of mercury. Upper limit is 30. Better if you can still maintain it at 25. So they recommended for ARDS, high PEEP over low PEEP, low tidal volume over high tidal volume. So low tidal volume should be used, high PEEP should be used, recruitment maneuvers should be used in patients who are in moderate to severe ARDS. Prone ventilation should be recommended for patients who have moderate to severe ARDS for more than 12 hours per day. NMBAs, that is neuromuscular blocking agents, are recommended as intermittent boluses or as continuous infusions also in patients who have moderate to severe ARDS. ECMO, we all now after COVID, we all have heard about ECMO, which is extracorporeal membrane oxygenation. So VV ECMO is recommended in severe ARDS if the center is able to have it, or if you have experienced center, please refer the patient to those centers for